Good evening. My name is Ivory Allison, and I am American Liver Foundation's National Director of Community Impact, and I'd like to be the first to welcome you to tonight's academic debates presented by the American Liver Foundation. We are excited about our topics, proud of our teams, grateful to our sponsors, and honored to have such an outstanding panel of judges alongside our esteemed moderator. We are grateful that you would take time out of your busy schedules to join us and hope you enjoy the evening. Tonight's academic debate is being delivered on the Zoom webinar platform and will be recorded. During the presentations, if you have one question, please hover your mouse over the bottom of your screen and click on Q&A. Then simply type your question into the Q&A box. For all other comments and to cheer on your favorite team, please use the Q&A box as well. Again, please note that this program is being recorded and will be available on ALF's YouTube channel for future viewing. As I mentioned earlier, we are extremely grateful for our ongoing sponsor support. We are so grateful to our premier supporter sponsors, AbbVie and ASI, for supporting the 2022 academic debates. Let's hear what our premier supporter sponsors have to say. We are so appreciative of our sponsor support. Without their support, we would not be able to continue to fulfill our mission. Before I introduce our moderator, I want to acknowledge tonight's technology team, Tyler Holderby and ALF's national team, Erica Bowder. We couldn't present tonight's event without their expertise. Thank you, guys. Now it's time to turn the program over to our moderator for tonight, Dr. Nora Terra, Professor of Medicine and Chief of Gastroenterology and Liver Diseases at the Keck School of Medicine at the University of Southern California. Dr. Terra received her MD from the University of Alberta and completed fellowships in internal medicine and gastroenterology at the University of Toronto. She also received her master's in public health from the University of California at Berkeley. Dr. Terra has focused her clinical and research activities on viral hepatitis and non-alcoholic fatty liver disease, especially in special populations, including those with cirrhosis and those with transplants. Tonight, Dr. Dawit will be saying a few words about the history and format of the debates and will explain how you can help support the mission of the American Liver Foundation, how you can promote the debates through our social media, and introduce our esteemed panel of judges for tonight's debates. I now turn it over to Dr. Dawit.
Well, thank you very much, Ivory. And I want to be the first to welcome everyone this evening. I'm extremely delighted to serve as tonight's moderator. As you know, this is the first night of the American Liver Foundation's Academic Debates Madness. And this is really quite an honor for me because the ALF has really led in this area and has hosted these debates for over 18 years. These debates are recognized for their educational excellence, and it's been a long-standing signature program of the ALF as well as the AASLD. It's one of the most popular non-CME programs among healthcare professionals in various medical disciplines and fields. And as you've heard, this year we are engaged in a week-long March Madness of academic debates, which start tonight and concludes on April the 1st. Each team will consist of 2 debaters and 1 mentor from one of the nationally recognized institutions. The format is well established. Each individual debate will feature 3 judges and 1 moderator. I have the privilege of serving in that role. And at the end of the evening, we will anoint the winning teams, and it's going to be based on the research they provide tonight, as well as their presentations of the case and of the rebuttal. I want to make you aware that the Medical Advisory Committee has set forth the specific subject matter and the perspectives that the teams are to argue. And the topics for this week's debates are really quite diverse: alcohol-associated liver disease, autoimmune liver disease, fatty liver, liver cancer, pediatric liver disease, and viral hepatitis. So we have sort of something for everyone this week. Tonight, it is our pleasure to present 2 very exciting debates featuring teams from the University of Southern California, the University of California, San Francisco, Fresno, Children's Hospital in Los Angeles, and Children's Hospital of Colorado. The topics assigned to the debate teams are specifically chosen because they're not settled in the medical literature, and they're a subject for debate. There is not necessarily here a right or wrong answer. And through these debates, what we hope is that we're going to stimulate everyone to think about these in a different way, to really, to ultimately impact the way we move the field forward. And of course, as is always the case for the American Liver Foundation, to impact the lives of people with liver disease. Now, the debates are fast-paced. We start each debate with a pro presentation followed by the opposing con presentation. Each side is allocated precisely 8 minutes to present. Should a presenter exceed his or her 8 minutes, we have a diligent timekeeper who will then disconnect their audio and video. No pressure. We will do our best to transition smoothly from one presenter to the next to keep the program flowing. I'm sure you're all going to have a lot of fun with this. After both arguments have been presented, each side will then have an opportunity to challenge their opposition with a 5-minute rebuttal. The debate teams will not use slides for the rebuttal portion. Again, they'll be closely timed, given 5 minutes for that component. And then there'll be a 5-minute question and answer session led by our panel of judges. I want to acknowledge upfront that this takes a lot of work to put on this event, both from the point of view of the demanding work on the part of their teams and mentors, but also we really appreciate the sponsors, AbbVie and Eisai, our judges, the timekeeper, and the technology teams. But most importantly, we want to thank you for joining us this evening, because indeed, that is what we most enjoy, is to have you all participating. So what I'd want to just share with you is a very special message. The American Liver Foundation has been a trusted voice for liver patients for 46 years. Its leadership and staff always strive to ensure that the foundation is a reliable source for patients, their caregivers, and for medical professionals. Educational programming has been presented consistently in a way that allows people to access information about a myriad of liver disease topics. And just as we're doing tonight, all programs are recorded and uploaded and available, made easy access, again, for patients, caregivers, and professionals. There's a special YouTube channel, in fact. There's printed literature that's been created and updated as the ALF's web pages about liver diseases are a really great resource, also a source for transplant-related issues. All resources available at no charge to the public. And they also have a national HEP line that remains a vital source of assistance for patients who want and need information about medical diagnostics, about various liver diseases, and links to financial aid, patient and caregiver support, and more. And it's through the advocacy efforts of the ALF that they continue to make certain that issues that are pertinent to patients in accessing care and treatment, that this remains a priority for all, including the legislators who make important decisions about healthcare policies. You're all probably aware that they have walks and marathons and patient and professional educational programs that are key components that unify the liver community. Now, of course, all of this great work cannot be done without generous support. The ALF is a non-for-profit organization, and as such, relies on donations to carry out its mission. So I ask you to please be generous tonight and to help the ALF continue to provide resources to the patients and caregivers, the healthcare community, and the general public. The fundraising goal for tonight is $5,000. Any and all support is greatly appreciated. So before I introduce our topic and team players, it is now my privilege to introduce to you our outstanding panel of judges. These judges will join us at the conclusion of each debate to ask the thought-provoking questions, and ultimately are the judges in terms of the winners of tonight's debate. So we have an outstanding panel, as I mentioned. Joining us from Cedars-Sinai Medical Center is Dr. Alakh Gulati, who's a professor of medicine and the associate medical director for liver transplantation at Cedars. He is board certified in internal medicine, gastroenterology, transplant hepatology, and has been involved in many clinical trials. He has diverse expertise, including areas of non-alcoholic fatty liver disease, cholestatic liver disease, viral and cholestatic hepatitis, and is, of course, an expert in liver transplantation. We also have Dr. Ray Chung joining us from Harvard Medical School and the Mass General Hospital. He's the director of hepatology there and of the Liver Center. He's the vice chief of gastroenterology, and he holds a Kevin and Polly Macroney Research Scholar position. He is well known to all of you for his great expertise in the arenas of viral hepatitis, particularly hepatitis C and hepatitis B, both its virology, pathogenesis, and hepatocarcinogenesis. And of course, he's the immediate past president of the AASLD. And then finally, and I'm really delighted to have Dr. Neil Chernoff join us. He is a gastroenterology and internal medicine specialist. He's the founding father of Arizona's first liver transplant program and became a founding father of the Arizona chapter for the American the American Liver Diseases Foundation in Desert Southwest. So thank you all for joining. I'm looking forward to the input of our judges this evening. So moving on now to the first debate. The key question here for our debaters is whether or not steroid-free immunosuppression should be a goal in all autoimmune chronic hepatitis patients. And just as a reminder, the pro presentation will be 8 minutes, followed by the con presentation of 8 minutes. Then we'll have 5 minutes for each of the rebuttals, and finally question and answers from the judges. So, steroid-free immunosuppression should be the goal of therapy of all autoimmune chronic hepatitis patients. On the pro side, University of Southern California. On the con side, University of California, San Francisco, Fresno. So, from the University of Southern California, I'm delighted, of course, to introduce my colleague, Dr. Jeff Kahn, who is the mentor for the team this evening. And the debaters that represent USC are Dr. Courtney Hanlon and Lillian Dawit. And then on the University of California, San Francisco, Fresno team, here the mentor is Dr. Marina Roytman. We have Dr. Alakh Gulati and Dr. Amitpaul Gill, sorry. And now we're going to get our debaters in position and begin our evening. Thank you.
Hi, everyone. My name is Lillian Dawit. I'm a third-year resident and rising chief at the University of Southern California. And today I will be arguing the pro stance supporting this statement. There's no doubt that steroids have an important role to play in the management of autoimmune diseases, especially AICH. However, we believe that the purpose of steroids and its use should be temporary in the setting of managing flares and poorly controlled disease. I could spend much longer than 8 minutes explaining why steroid-free immunosuppression is the way to go. Oh, can you see my slides? No? Oh, you can't? Is it not working? Is that better?
Yes.
Oh, okay. My apologies, everybody. I will start over. Okay. To start over again, my name is Lillian Dawit. I'm a third-year resident and rising chief at USC, and today I will be arguing the pro stance supporting this statement. Okay, so as I mentioned, there's no doubt the role of steroids that it has to play in managing autoimmune disease, especially AICH. But we believe that the purpose of steroids, its use should be temporary when we manage flares and poorly controlled disease. So although I only have 8 minutes to explain our side, I really want to focus on these 4 important reasons supporting our stance. Number 1, steroid-sparing regimens do work in the management of AIH. Number 2, steroids can cause and worsen fatty liver disease. Number 3, steroids have known avoidable side effects. And number 4, new non-invasive techniques to assess liver fibrosis does allow for closer monitoring of AIH disease status during steroid-free remission. Now, I want to be clear about what we're debating and the definitions at hand. Chronic AIH is AIH in which remission has been induced with continual biochemical evidence of remission. The scope of this debate is not about first-line treatment or induction of remission. We're not arguing that steroids should never be used. Where the waters get murky is after remission has been induced or in difficult to treat patients. What we're debating here today is whether or not patients should be on steroids indefinitely. Ultimately, shouldn't we try to transition to steroid-free regimens to avoid some of the worst, most common side effects? Well, first we have to answer the question, is there evidence to show the efficacy of steroid-free regimens? The answer is yes. This landmark study, published in the New England Journal of Medicine in 1995, looked at 10-year follow-up data for a cohort of 72 patients who remained on azathioprine alone after induction of remission with prednisone and azathioprine. With the primary outcome being clinical remission, 100% of patients remained in remission after 1 year off of prednisone, and 83% of patients remained in remission after 10 years of steroid-free treatment. To further support this, a meta-analysis in 2010 identified 4 clinical trials that focused on AIH patients in remission and on maintenance therapy. These studies included over 160 patients in 6 different arms, and the results showed that both azathioprine and prednisone plus azathioprine yielded a higher rate of maintaining remission than prednisone alone. Furthermore, maintenance treatment with prednisone plus azathioprine was not better than with just azathioprine alone. So we do have the data to support this. Steroid-free regimens can be utilized in our AIH patients with the added benefit of avoiding the side effects of steroid use. Speaking of side effects, let's talk about them. Although steroids are widely used in the autoimmune diseases, there are numerous side effects to both short-term and long-term steroid use, including neuropsychiatric disorders, osteoporosis, high blood sugar, myopathy, vascular disease, infection, water retention, which is very important in our chronic liver disease patients, obesity, infertility, cardiac disease, cardiac hypertrophy, moon phases, psychosis, hepatic steatosis. The list goes on and on and on. And it's important to note that there are risks associated with prolonged periods of time on any dose of steroid. Remember too that many of our patients with AIH are young, even children. So the longer that they're taking steroids, the more complications they'll experience. So you have to have a goal of avoiding this in your patients. We all know that patients do not like taking steroids and want to come off of them as soon as possible. What we also know is that unfortunately, not only do our AIH patients have to carry the mental health burden that comes along with a chronic inflammatory disease, but with steroid use, the quality of life within these patients is far poorer. Using objective measurements to assess health-related quality of life, data published in Hepatology has shown that steroid use in AIH is strongly associated with decreased health-related quality of life, independent of remission status. Patients were observed to have very high rates of severe depression and anxiety, and this only highlights the need for focusing on steroid-free therapy goals. So what about weight? Let's not forget about this number. 42.4 is the percentage of people just in the United States who are overweight and obese. Steroids potentiate weight gain, and it's ultimately associated with the development of comorbidities like metabolic syndrome and diabetes and hyperlipidemia. And as we know, in addition to the steroids' direct effects, all of these complications themselves also contribute to the development of fatty liver disease. In obese adults, the prevalence of NAFLD is 80 to 90%. And as it relates to AIH, NAFLD is present in the biopsies of 17 to 30% of AIH patients, and unfortunately, long-term steroids can drastically affect the course of this. A study published in 2016 in Digestive Diseases demonstrated that patients with this overlap syndrome were more likely to present with cirrhosis and were more likely to develop adverse clinical outcomes with decreased survival. So knowing these complications is just another reason why we should come off of steroids. So the next question comes, how do we monitor these patients? The good news is that we're in the 21st century and technology has continued to grow our ability to monitor patients using non-invasive techniques. With the advent of the transient elastography, such as FibroScan is here, or MR elastography, we're now able to monitor disease progression and fibrosis in our AIH patients. And of course, for those in whom the results are not as clear, we always have biopsy to rely on. If you don't take my word for it, let's look at the guidelines. It's been very clear in multiple major liver societies that withdrawal of steroids is the goal of therapy. For example, the AASLD recommends trying to taper and attempt withdrawal of both prednisone and budesonide in AIH patients, even in asymptomatic patients with inactive cirrhosis. EASL also recommends that steroid-free monotherapy with azathioprine or mycophenolate should be the goal of therapy. We have guidelines for a reason, and these both emphasize our goals of steroid-free maintenance therapy very clearly. Ultimately, this is about weighing risks and benefits. What happens when the treatment is worse than the disease? Again, we accept that steroids have their part to play in the management of AIH. However, we have evidence to show that steroid-free maintenance therapy in patients does work. We know steroids have very bad side effects, and we have ways to monitor our patients after the withdrawal of steroids. For the majority of other autoimmune disorders, RA, lupus, significant strides have taken place to facilitate corticosteroid-free regimens. The goal is never to keep on on steroids forever. It's a means to an end that is hopefully steroid-free. So why can't our goals be the same? And I end this talk asking the same question with which we started. Given everything we discussed, should steroid-free immunosuppression be the goal of therapy in AICH patients? Should eventually taking our patients off of steroids when safe be what we strive for? To that, I say absolutely yes. Thank you very much for your time.
Okay, thank you. Wonderful start. Now we're going to move on to the opposing team. So we're going to call on Alakh Gulati from the University of California, San Francisco, Fresno, who's going to now present the Kahn position. Timekeeper, are you ready?
Hi, everyone. I'm Alakh. I'm one of the GI fellows at UCSF Fresno. Just want to thank everyone for participating in this debate. Thank my co-fellow, my mentor, and thank you to USC for a great argument. And we're going to argue, we feel very strongly that steroid-free immunosuppression should not be the goal of therapy in autoimmune hepatitis patients. All right, so we're going to begin today by meeting a patient, Mrs. RS. She's a 50-year-old female patient with a history of hypothyroidism. She presented to her PCP with a chief complaint of fatigue and generalized weakness. One of our residents at the resident-run clinics at UCSF Fresno saw her and ordered their usual normal labs. And he noticed that she had some abnormal liver enzymes with the elevated ALT and elevated AST, and she was referred to our hepatology clinic. We pursued some standard imaging that didn't really show any definitive abnormalities. We pursued a thorough chronic liver disease workup, and she was found to have elevated ANA, a positive anti-smooth muscle antibody, and elevated serum IgG. Our suspicion was very high that she may have autoimmune hepatitis, so we pursued a liver biopsy. She was found to have interface hepatitis. We felt very strongly that she had autoimmune hepatitis at this time. We started her on steroids, and 2 weeks later, her labs demonstrated a good response. And we added azathioprine for her therapy. 6 months later, her prednisone dosage had been tapered down all the way to 5 milligrams, and her labs demonstrated a very good response. She appeared to have achieved biochemical remission. The patient did report some known side effects of steroids, such as weight gain, and after a thorough physician-patient conversation, steroids were removed. Unfortunately, a month later, her liver enzymes again uptrended, and we were concerned for relapse. Was it worth to remove the steroids? We're going to go through that in our presentation. Let's take a trip back to the 1970s when some of the sentinel trials were done to demonstrate the effectiveness of steroids and why it's important to use steroids in the treatment of these patients. We're going to start off with a Mayo Clinic study by Dr. Soloway, in which they looked at 63 patients who were divided into 4 groups almost evenly, groups which involved receiving prednisone, receiving only azathioprine, receiving prednisone and azathioprine, so combined therapy, and receiving placebo effect. And what they demonstrated was that the patients who received prednisone alone appeared to have low mortality rates compared to those who had only received azathioprine. The mortality rate in the prednisone alone group was about 6%, while the mortality rate in those receiving azathioprine was up in the 40s. Prednisone and the combined therapy also demonstrated better clinical and biochemical improvements at both 3 and 6 months. There was better histological improvement also noted at 6 months. Similarly, as they continue to show, there appeared to be a better clinical, biochemical, histological remission in groups that had received the prednisone therapy versus those who had not. And similarly, there was less treatment failure for those who had received prednisone compared to those who had not. A similar trial also looked at similar 4 patient groups of receiving prednisone, combined therapy, and those receiving azathioprine alone. And again, it demonstrated that biochemical remission was achieved in about 80% of patients who had received some form of prednisone therapy, while only 30% in those who had not received any form of steroid therapy. Histological remission also was achieved in about 60% of those who had received some form of steroid therapy, And unfortunately, only 19% of those would not receive any steroid therapy. And then to further solidify our argument, the importance of steroids, another trial, a double-blind prospective trial of prednisone versus azathioprine in the treatment of autoimmune hepatitis was performed. And over a 2-year period, it demonstrated that the groups that had received prednisone had a better survival rate and also a better biochemical remission rate than those who had not. Now you may ask, why are we harping on the fact that it's so important to achieve this biochemical remission with the use of steroids? Well, that's because studies have demonstrated that it's very important and critical to achieve biochemical remission, especially within the first year of therapy. So that's why we feel it's very critical to have steroids on board to make sure that we can achieve that biochemical remission. There was a study done that looked at a group of 250 patients almost, most who had received steroids. And looking at these patients, what they noted was that the patients who had achieved biochemical remission within the first 12 months seemed to have a better prognosis than those who had not. Now, similarly, when we then looked at the ASLE guidelines, we felt that really the 4 pillars of goals that they had outlined was that we need to focus on improving symptoms, controlling hepatic inflammation, achieving biochemical remission, and preventing disease progression. There really wasn't any strict guidelines in terms of removing the steroids. While that is something they recommended physicians could consider, these are really the 4 pillars that they wanted us to focus on. Now, we understand that steroids have their side effects, but we do have better agents in our arsenal as well, specifically budesonide, a steroid that has lesser side effects and is more tolerable. A landmark trial done by Dr. Manns and his group was a 6-month prospective double-blind randomized control trial that compared budesonide versus use of prednisone. And the primary endpoint was biochemical remission, which was defined as normalization of the AST/ALT levels without any steroid-specific side effects. And those who were in the budesonide group were able to achieve that about a 47% rate versus those who were in the prednisone group. So yes, we acknowledge that steroids can have their side effects and physicians may not want to use them. But if you can use a different steroid such as budesonide, then we feel strongly that's the way to go. And lastly, we feel that's very important in healthcare these days that we must pay attention to groups that have been marginalized. And a paper that was written by Dr. Kahn at USC, they examined the healthcare discrepancies in patients with autoimmune liver diseases. And they identified that African-American patients may present with more severe phenotypic presentations. They may present at a younger age, they may have more severe disease, and their disease may be more aggressive. And these patients may require greater amounts of corticosteroids to maintain remission. So in this rush to take off the steroids, should we marginalize these groups and not make sure that we take care of them so their disease doesn't advance? So let's turn to Mrs. RS. She came back, she was placed on steroids, her labs improved, and 2 years later, the liver biopsy demonstrated no active hepatitis. Biochemical and histological remission was achieved. We were able to finally achieve that goal without rushing to take off the steroids. So we feel, once again, that the goal is disease control, not the focus on withdrawal of steroids. It's important to prevent disease progression. Budesonide can be used as a safer choice, and steroid-sparing agents have their own side effects. And at the end of the day, one approach does not fit all. As physicians, we must strive to eliminate healthcare disparities, and that starts by recognizing different phenotypic presentations.
Okay, that was also excellent. Thank you. We're going to move on to the rebuttals now, and I'm going to ask Courtney Hanlon from the University of Southern California to rebut the UCSF position. Courtney.
Thank you very much, Dr. Terrell, and thank you to everyone for being here tonight. From the USC team, we appreciate everyone who's here, and we really appreciate UCSF's ability to engage in this discussion. A few things that I'd like to bring up. First of all, I really appreciate you bringing up the original trials back from the Mayo Clinic back in the 70s, back when President Nixon was president, and I believe all of those primary investigators are now dead. But you are absolutely right. In the very first trials back in the 70s, prednisone was shown to, and actually does have a very significant effect on induction of remission. We are not arguing that prednisone does not help to induce remission. Actually, that's not the scope of this debate. What we're debating is, once you have remission, does taking off steroids help to reduce the rate of side effects for these patients? And so, yes, there is recurrence. There's going to be recurrence. There was a Danish registry that looked at over 1,700 patients with autoimmune hepatitis, and clinically, in practice, somewhere between 50 and 90% of patients will relapse within 12 months of drug withdrawal. However, with retreatment, over 80% of these patients will again achieve clinical remission, not only clinical remission, but biochemical remission. Nowadays, we have treatments other than prednisone, other than budesonide, such as azathioprine or MMF, that can keep this remission in patients, both biochemically and histologically, without the need for steroids. And as we know, steroids have tons of effects. Speaking of which, I am so thrilled that you brought up budesonide, which also is a steroid as well. But that's actually the last randomized clinical trial for AIH therapy since Richard Nixon was president, since the prednisone trials back in the 70s. And yet it is still not relevant to the debate at hand, because that trial looked at budesonide plus azathioprine versus prednisone plus azathioprine. And it was looking at inducing remission and seeing if patients could keep remission. I believe it was at 6 months, seeing what their steroid side effects were. That was good evidence to show that budesonide is an effective alternative to prednisone. However, that was short-term use of budesonide. There's actually no good evidence supporting long-term use of budesonide, and yet still that is a steroid which we would actively like to avoid in our patients. What I'd like to point out, as Dr. Dawit very astutely showed, is that this is the 20th century. We have ways besides biopsy of measuring for recurrence and progression of disease. The fibroscan, or the transient elastography, correlates very well with autoimmune hepatitis, and then MRE elastography even better for staging of liver fibrosis. It has a sensitivity of 90% and a specificity of 100%, positive predictive value of 100%. So we can be following these patients non-invasively, be able to take them off of prednisone and budesonide while we monitor them closely. So it's really a question of, if you're able to monitor your patients closely, it's unlikely that you'll ever have a patient with a flare that will significantly affect their health. You can almost get them back into remission, almost all of your patients, while monitoring them non-invasively. It's really about avoiding as many steroid years as we can, and I think that's often a goal in other diseases, such as post-liver transplant and any other autoimmune disease. Really, you're trying to avoid as many years on chronic steroids as possible. I think our colleagues would agree that's typically the goal of any treatment. You'd like to get someone on the lowest effective dose of steroids as possible. And luckily in this day and age, that lowest effective dose is 0. So I just want to reiterate that, if you follow your patients closely, even if they do have progression, you're able to get them back on treatment, often steroid-free treatment, that keeps them either at a stable state, normal ALT, AST, normal IgG. But even if you're going by histology, we have non-invasive measures to look at progression.
Okay, Courtney, thank you. And now I'd like to invite Amitpaul Gill, who is going to, from UCSF president, who's going to now rebut the USC position. Amit?
Hi, thank you everyone for putting this together. So first I want to thank Team USC for your remarks. Although, we acknowledge the points you made, I just want to take a few minutes to offer some counter arguments. So first, you guys talked significantly about the side effects of systemic steroids. We do recognize that steroids do have some well-documented side effects, as you illustrated in your presentation. But I just want to reiterate that we do have alternative steroids that can be used, such as budesonide, as my colleague mentioned. And I just wanted to touch about budesonide a little bit more. There was a meta-analysis done in 2020 that was published in Hepatology that looked at budesonide in combination with azathioprine versus prednisone and azathioprine. And there were two studies that were included in this meta-analysis, one being the randomized control trial that my colleague touched upon. And that trial showed greater rate of biochemical remission and fewer side effects. And the other study was an observational study comparing budesonide and azathioprine versus prednisone and azathioprine. And the results from this study also showed that budesonide-based therapy led to a higher rate of biochemical remission, 64% of patients versus 52%. And overall, the authors concluded that budesonide and azathioprine in combination should be used as first-line therapy. So from our standpoint, this just goes to show that alternative steroids can have significantly less side effects and be equally, if not more effective than the kind of traditional steroids that were used in the past. The second point I want to make, we feel like steroids are absolutely necessary for immunosuppression, as they can provide rapid biochemical improvement. We feel like the rapid biochemical improvement is not only good for the short term, but for also long term to prevent disease progression. And this was highlighted in one retrospective analysis from 2009. This retrospective analysis looked at rapid treatment affects outcomes in autoimmune hepatitis. And the study actually, the results were interesting. The patients that were treated rapidly progressed to cirrhosis less frequently. The patients that responded rapidly progressed to cirrhosis about 18% of the time, versus the patients that were delayed treatment developed cirrhosis 54% of the time. So a significant difference there. And also patients that were treated rapidly required liver transplantation less often. So from our perspective, this demonstrates that achieving remission rapidly is warranted, and treatment with steroids alone can achieve this. And other studies have also shown that delaying biochemical remission can increase the chance for relapse. I think this is an important point to make because it can be challenging to acquire remission after relapse. And with each exacerbation and each retreatment, the chance for sustained remission decreases by 14%. We feel like it is prudent to use steroids for immunosuppression for the rapid treatment, which not only improves immediate outcomes, but also long-term outcomes. Lastly, I want to talk about the side effects. You guys mentioned about azathioprine and these newer medications that can be used, but they also have a lot of side effects that go under-recognized. And we feel like steroids in this debate are being singled out in terms of side effects. So I just wanted to touch about the side effects of azathioprine. Azathioprine affects about 10 to 20% of patients that are treated with it. The most common side effect being bone marrow suppression. It can also cause hepatotoxicity, acute cholestatic hepatitis, pancreatitis, nausea, vomiting, and opportunistic infections. And lastly, I feel like this is under-recognized malignancy. And there's actually one study looking at disease control by azathioprine monotherapy. And over a median follow-up of 12 years, 7% of patients develop malignancies in this study. So we feel like azathioprine has its own set of side effects that need to be considered before starting therapy and considering patients for long-term therapy, given this concern of these side effects, especially the most feared complication, malignancy. The question we ask is, steroids do have well-known side effects, but are they worse than the other steroid-sparing agents? So we feel like when starting therapy for patients, steroids should definitely be considered and be used for immunosuppression going forward. Thank you.
Terrific. Thank you so much. We're now going to move on to the question and answer period. We're going to call on our judges to ask each of our debating groups questions. So if everybody could, got their cameras on. Okay, great. Perfect. So maybe I could start by asking, Everybody okay there? All right. So what I'm going to start with is if I could ask Dr. Chung to start off, to lead off the questions, indicate which team you would like to ask, and take it away, Ray.
Well, first of all, I just want to congratulate both teams for really making wonderful cases for what is I think what we might have thought was a slam dunk kind of question just on the face of it, but you really, I think, nuanced the discussion really beautifully in terms of thinking about both sides of the coin. And so I would direct my first question to the UCSF team who had argued that steroid-free immunosuppression should be the goal. How would you view the statement that there should be attempts to wean patients off of steroid-containing immunosuppression generally? Do you object to that general theme as a goal of treatment, broadly speaking? And I'd just love to hear what your view of that particular therapeutic goal is, to at least make the attempt to try to get patients off of steroids. This is for the UCSF.
Hey, Dr. Chung. Yeah, thank you for that was a great question. That's always a challenging question. And we think about that. The patient we presented in our case, she was on steroids for about a year, and they were withdrawn on steroids at that time, and she went back into a relapse. It's all those steroids should be used, and we feel like once patients do get biochemical remission, the goal should be to try to get off all therapy and give the patients a chance to see if they stay in remission. So I think if the patients have well documented they've been on steroids and they're in biochemical remission, you get a liver biopsy showing that they're in remission, that I think it's worthwhile to try to take them off steroids and all medications at that time, just to reduce all their side effects. But I think it is worthwhile to do it at once if the patient can tolerate it.
Thank you very much. Did your teammate want to weigh in at all?
Yeah, I think. Sorry about that. Yeah, I think it is important as a physician. It's always a difficult discussion between the physician and patient. Balance the benefits of steroids, but also the side effects. And I think that if you can show that you've achieved biochemical remission, and if a patient feels that they would want to try off of the steroids, then I think it's important to go towards that goal. But I think we would just reiterate is that we feel that it's important not to make sure you don't rush taking patients off of steroids, even though there are side effects to it, because like my colleague had mentioned, when patients relapse, it increases the risk that in the future their disease is going to progress. And I think the main thing, like in other autoimmune diseases, like in IBD, we're aiming for basically good immune control. Same in autoimmune hepatitis. We want to make sure we get good disease control, because we want to make sure we don't let the disease progress. So I think we would say that we do admit there are some side effects with steroids, but at the end of the day, I think we would be willing to take some of those side effects if it meant that it could prevent the progression of disease for the patients.
I'll let my other colleagues ask questions. I don't want to.
Maybe before we leave, I always want to give both sides a chance to respond to a question. So does anybody from the USC team want to comment, either in response to what your debating colleagues might have just said?
Sure, absolutely. I would just like to say I agree with UCSF Fresno that we should attempt to take patients off of steroids. I think there was somewhere in their slide deck a bit of a low blow, citing some USC investigators looking at African-American patients with autoimmune hepatitis and suggesting that there's some rushing involved in taking patients off of steroids. But this debate is not about whether we should be rushing to take patients off of steroids. No one agrees with that. We should never rush to take patients off of steroids, but I do agree with you that it is absolutely the goal of therapy.
Thank you. So now I'm going to move on to Dr. Chernoff. Would you like to ask a question of the teams?
Actually, I would. I actually have two questions that I'd like to present to UCSF. The first one is, what dose of budesonide would be comparable to the standard prednisone dosage. That wasn't clear to me. Did that question come through?
Yeah. So the study that looked at budesonide had used budesonide at 3 milligrams TID or 9 milligram dose. But the goal would be to also down titrate that, I mean, if possible. But at least the Dr. Mann study had looked at 9 milligrams. It was a 3 milligrams TID. What they had looked at.
Okay, which when you have 10% of that absorbed into the body, only 1 milligram is going to the liver. Roughly 1 milligram doesn't seem like a lot. I can certainly see where that would be useful, bathe in the intestinal tract. The second question, and perhaps your colleague would answer this one, have there been any studies that you came across that using budesonide alone for treatment?
No, I didn't see any studies just looking at budesonide on its own. Most of the studies I did see were in combination with azathioprine. Budesonide, in those subset of patients, like I said, it did have a good response. It went in combination, but there's no studies that I saw myself that were just budesonide alone.
Thank you very much. And this was a very stimulating conversation, because this is a question that I've wondered about for a long time as well. So thank you all for that.
All right, we're gonna, I want to make sure we get to all our judges. So I'm going to ask Dr. Ayu. Can I get you to also chime in and ask our debaters a question or two?
Of course. I mean, this is quite an excellent discussion about pros and cons of steroid-free therapy. My question for I'm going to start with the USC team. You mentioned you use FibroScan to monitor disease progression in autoimmune hepatitis. But the goal for autoimmune hepatitis is to monitor inflammation. So how would you use a FibroScan to monitor inflammation?
Maybe I can try and answer this question. So there's actually an AASLD guidance that states that you shouldn't be using FibroScans until about 6 months after induction of therapy, because it can identify, or because of the hepatic inflammation, you want to give it time to come down. But I think the goal of actually the FibroScan is more for assessing progression to cirrhosis and the severity of fibrosis in these patients. And our point was more saying that in these patients, we have techniques after a year or two of being in remission of being able to monitor their progression of disease, as opposed to how inflamed, after they're already in remission, as opposed to flares or how much inflammation they've been having at the time. I hope that answered the question that you were asking.
It did. Now, I have a quick question for the UCSF team, if allow me. You mentioned a budesonide. You're advocating for a budesonide, but the budesonide is quite expensive. So is it cost effective? Have you come across any cost effective study to show the combination azathioprine, budesonide, or a budesonide alone is cost effective compared to standard of care for with a prednisone based therapy?
To specifically address the question, I don't know of any. I don't know of any papers, I would say, that demonstrated that. So if you have some, we would be happy if you could share those with us, actually. But I would say at least the cost effectiveness. I'm not aware of anything demonstrating that budesonide is more cost effective.
Because I haven't had a success in getting budesonide approved in the first round for autoimmune hepatitis. Usually you have to go 2 to 3 times arguing to get it approved for your patient?
Maybe it's easier in Fresno.
All right, thank you.
All right. I'm going to give, again, I always like to try to give a little bit, a last minute question. So I'll just come back to all my judges and ask, are there any final questions for our debating teams before we close? I got a shake of the head. Ray, we're okay? Okay, great. Okay, Waleed, we're okay. All right, great. All right, then I want to just say that this has been a fantastic debate. I want to thank the debaters. I want to thank the mentors in particular for very, very strong performance here. It's been really very, very exciting, I think, to kind of get to this phase. We're now going to have the judges do their voting. We won't know until the end of this program, so stay tuned. We're now going to actually move on to debate number 2. So just to introduce this second debate, and I'm very excited that we have our pediatric colleagues with us this evening. So the key clinical question for this debate is whether or not gastric bypass should be the treatment of choice for NAFLD with moderate cirrhosis in adolescents. So again, a similar format to our first debate. We'll have the pro presentation for 8 minutes, con presentation for 8 minutes, then 5 minutes each to rebut the opposing team's presentation, and then we'll follow with the Q&A. And so we're very excited to have the 2 institutes represented this evening. On the pro side is Children's Hospital of Los Angeles, and on the con, Children's Hospital Colorado. So now let me introduce our debate teams. So presenting the pro position that gastric bypass should be the treatment of choice for NAFLD with moderate fibrosis in adolescents is the Children's Hospital of Los Angeles team. Their mentor is Dr. Rohit Kohli, and our debaters are Eric Dubrow and Nassim Rababashir. And I really apologize, Nassim, if I really didn't do such a great job there, but I'm trying. And on the Children's Hospital Colorado, to argue the con position that gastric bypass should not be the treatment of choice for NAFLD with moderate fibrosis in adolescents. Here, the faculty mentor is Dr. Amy Feldman, and our debaters are from Children's Hospital Colorado are Dr. Priya Ralphs and Dr. Elisa Goldman. So let us lead off. It's going to be Dr. Nassim, who's going to be presenting from Children's Hospital Los Angeles, their initial position. If we could just get the timer, please.
All right, I'm going to go ahead and start. Okay. Hello, everybody. My name is Nassim Ravenbach. I'm from Children's Hospital of Los Angeles, and I will be discussing bariatric surgery and the treatment of NAFLD. I will focus on bariatric surgery, which is not limited to gastric bypass, as the 2 more common procedures at present day include both gastric bypass and sleeve gastrectomy. So as we know, there is a rising incidence of NAFLD diagnosis that has significantly increased over time. NAFLD is the leading cause of liver disease in adults, and obesity rates among children continue to rise, and this corresponds to an increase in the NAFLD prevalence among children. And currently, NAFLD is the most common chronic liver disease in childhood. And looking at this table, this demonstrates almost a doubled incidence between 2009 and 2018 among children with NAFLD. So this is a histogram that shows the percentage of these patients by their age at the time of diagnosis, and we're going to be focusing on the adolescent timeframe. So treatment options of NAFLD include, as we know, diet, exercise, weight loss, and bariatric surgery. And weight loss is among the most effective treatments for NAFLD, and lifestyle interventions are certainly first line, but sometimes, in most situations, this effectiveness is often short-lived. So we're going to be focusing on bariatric surgery. Bariatric surgery is the only treatment option that has shown long-term and successful weight loss, as well as improvement in comorbidities. It's an effective treatment option for NAFLD, and it may help avoid NAFLD progression to end-stage liver disease, as well as necessity of liver transplantation. There are many bariatric surgery types. And again, we're going to be focusing in on the vertical sleeve gastrectomy and the Roux-en-Y gastric bypass as the two more common procedure types. So the biggest question is gastric bypass an effective treatment modality in NAFLD? The adult literature says yes. This is from a study, from an adult prospective study that evaluated the biological and clinical effects of bariatric surgery in patients with NAFLD. And over a period of 19 years, the study followed 109 morbidly obese adults with biopsy-proven NASH who underwent bariatric surgery, and they collected all this data before and 1 year after surgical intervention. What they ultimately found is that 1 year after bariatric surgery, NASH had actually resolved, completely disappeared in 85% of the patients. And according to Medivir indices, fibrosis was also reduced in about 34% of the patient population. So more on fibrosis. Now, this graph is from another study that aimed to evaluate the improvement of NAFLD in the two more common procedures, including laparoscopic sleeve gastrectomy and Roux-en-Y. And they evaluated patients both preoperatively and postoperatively with liver stiffness as measured by transient elastography and laboratory-based fibrosis scores. And what they found was that mean liver stiffness improved over 12.5 months. Fibrosis decreased from 48% preoperatively to 16.5% after 1 year. And the mean fibrosis stage improved from F3 to F1. Ultimately, the post-op liver stiffness improved in the majority in 94% of the patients postoperatively. Fibrosis be gone. So this is a third study, and this is a prospective observational cohort study that enrolled obese adult patients who underwent Roux-en-Y gastric bypass. What they tried to do is determine the evolution of liver disease, evaluating NAFLD fibrosis scores, actually also 12 months after surgery. And they obtained routine liver biopsies during surgical intervention for all patients. And what this table shows us here is that the most observed stages of liver fibrosis were stages 1 and stages 2. And gastric bypass surgery showed a decreased NAFLD fibrosis score, as well as resolution of severe fibrosis in the majority of patients. This shows both laboratory and clinical features before and after surgery in the same study that I just cited. And as you can see, there are clinically significant improvements in many features, notably body mass index, ALT, AST, as well as NAFLD fibrosis score. So this study is a systematic review. These graphs are coming from a systematic review and meta-analysis, and they included 32 studies that reported on this very topic and ultimately provided forest plots of biopsy-proven complete resolution of NASH features, including resolution in steatosis in 66% of the patients, resolution of lobular inflammation, improvement in ballooning degeneration in 76% of the patients, as well as resolution in fibrosis in 40% of the patients. So in conclusion, bariatric surgery led to histologic resolution of NAFLD in a significant portion of the patient population. So when you think about sleeve gastrectomy versus the Roux-en-Y, this is what I'm quoting, what I'm citing right now is a systematic review and a meta-analysis separate that showed that sleeve gastrectomy and Roux-en-Y are actually equivalent in effectiveness for controlling NAFLD, and there are improvements in both steatohepatitis and fibrosis for both procedure types. So here comes the biggest question: is gastric bypass an effective treatment of NAFLD in adolescents? The literature also suggests that it is indeed effective. So this is an article from the New England Journal of Medicine. It's a multi-center prospective study of bariatric surgery in the adolescent population. And the study enrolled 242 adolescents who underwent bariatric weight loss surgery at 5 separate US centers. And they included both procedure types. And what they're showing here is that the study ultimately showed progress in cardiometabolic health, weight, and quality of life in these patients. And at the 3-year time frame, the mean percent weight loss was 27%, and the overall cohort, 28% for those who underwent gastric bypass and 26% who underwent the sleeve gastrectomy. So at this 3-year mark, they also cited improvement in type 2 diabetes, remission in 95% of the patients, as well as improvement in abnormal kidney function, prediabetes, and dyslipidemia also in the majority of patients. So what they found was that these studies suggest that bariatric surgery is safe and effective for obese adolescents with NAFLD, and it helped improve NAFLD scores as well as resolve metabolic syndrome. So this is another study that included 20 obese patients, adolescents who underwent laparoscopic sleeve gastrectomy with biopsy-proven NAFLD. And they compared baseline and 1 year after treatment And with the biopsy samples at time 1, which is 1 year later, showed improvement in steatohepatitis and fibrosis when compared with baseline biopsy samples. So I'm pointing up here at the improvement in steatosis, as well as down here, this improvement in the fibrosis. And similarly, liver biopsy samples, so this is the same study, showed clinically significant improvement of NAFLD activity score and fibrosis when comparing histopathological features at baseline and at the 12-month timeframe. Complications, of course, we are aware that there are risks and complications associated with every surgical procedure, including abdominal organ injury, infection, wound dehiscence, you name it, we know that. But at the same time, overall rates of complications are actually lower in adolescents than they are in adults. And bariatric surgery has actually undergone complete evolution over the years. And the complications, one study can be cited as low as 2.59% in the adolescent timeframe. What we also know is that the transition to laparoscopic sleeve gastrectomy has improved the safety profile of bariatric surgery. Also, obese patients have quality of life scores similar to that of oncology patients who are actively undergoing chemotherapy. Clearly, there's a call for intervention. And bariatric surgery has been established as an effective method to treat obesity-related diseases. So our takeaways is that NAFLD is the most common liver disease in children, and the incidence continues to rise. Weight loss is the most effective treatment for NASH, as well as improving the comorbidities. Bariatric surgery in adolescents has ultimately been proven to be safe and effective in producing long-term weight loss and improvement of NASH.
Wonderful, thank you. I love the use of hands. It's a little bit like me as well. So thank you. Well done. All right, we're going to move on to our next presenter, which is from Children's Hospital Colorado. This is Dr. Elisa Goldberg, who is going to present the Kahn position of this debate. Elisa?
Thank you. So my name is Alyssa Goldberg. I'm a pediatric GI fellow at Children's Hospital Colorado, and I'll be presenting the Kahn argument that gastric bypass should not be the treatment of choice for NAFLD with moderate fibrosis in adolescents. I want to start by mentioning that for adults, the American Society of Metabolic and Bariatric Surgery just said in a position statement published earlier this month that takes into consideration the data presented by the CHLA team that bariatric surgery should be considered as a therapeutic tool among patients with severe obesity, but randomized controlled trials are needed to determine whether bariatric surgery should be considered as a frontline therapy for NAFLD and NASH. So my first point is that even with that, the adult data cannot be extrapolated to adolescents. It can't be generalized to adolescents because the populations are different. In this MGH study, comparing adult and pediatric populations, they had a difference in mean BMIs. The adults also had higher rates of comorbidities associated with metabolic syndrome, including hypertension, dyslipidemia, and type 2 diabetes. When we look specifically at liver disease in these populations, they also differ. Adults have higher rates of steatosis, higher rates of steatohepatitis, and in focusing on our debate question at hand, higher rates of fibrosis. Thus, we shouldn't generalize the adult data presented to our pediatric population. Secondly, if we just focus on that adolescent data, there isn't sufficient evidence to make recommendations for bariatric surgery as the treatment of choice. So again, let's return to the question posed in this debate of whether bariatric surgery should be the treatment of choice in adolescents with obesity, fatty liver disease, and moderate fibrosis. So on the left, you see data from the Teen Labs Consortium of adolescent patients who underwent bariatric surgery. You can see that moderate to severe fibrosis is rare, occurring in only 4% or 6 total patients. So we can't draw conclusions about general outcomes for this population based on the 6 patients. The study by Manko and colleagues looking at sleeve gastrectomy and hepatic fibrosis only looked at 20 patients undergoing sleeve gastrectomy and only included 1-year follow-up. It was designed as a pilot study, and so it's also not powered to make consensus statements. The third point is bariatric surgery is a major surgery with potential short and long-term complications in the adolescent population. These complications include most seriously death in 2% of the adolescent population in a study published by Dr. Inge. Further, up to 20% of patients require repeat surgeries. In fact, a higher percentage of adolescents than adults required these repeat surgeries. Surgeries were most commonly cholecystectomy, but that number is followed closely by surgery for bowel obstruction, which is a serious postoperative complication. Additionally, nutritional deficiencies were found in the majority of patients, including almost half with clinical anemia, 78% were found to have low vitamin D, and many patients had substantial decreases in bone mineral density that was sustained after 2 years. Also, patients were found to have micronutrient deficiencies if their supplements were not taken as prescribed. We don't have data on the long-term effects of all these nutritional deficiencies in our adolescent population. And this will be especially important in our adolescent patients because some of them are still growing and haven't reached skeletal maturity. My fourth point is bariatric surgery programs require unique resources to care for adolescent patients, and these centers are not widely available. The use of bariatric surgery is restricted to a small subset of pediatric NAFLD patients. While the mean BMI of pediatric NAFLD patients is the 98th percentile BMI for age, the ASMBS recommends patients be considered for bariatric surgery when they have a higher BMI of 120% of the 95th percentile, plus a clinically significant comorbid condition such as NASH. Even for those children who do qualify, this is not a universally available resource, as programs who care specifically for adolescents require specialized resources, as recommended by the American College of Surgeons, including this multidisciplinary team noted here, including a medical provider, a surgical provider, a psychologist or behavioral specialist, a program coordinator, and very importantly, a transition plan into an adult program. This structure is important because many adolescents are unable to adhere to the lifestyle interventions necessary to enter into bariatric surgery programs. Adolescents are reliant on caregivers for all of their needs, including follow-up visits, medication compliance, and finances. At age 18, some patients may need to quickly transition to adult centers where these supports aren't in place. In some, because bariatric surgery is not universally available, it's not equitable to offer as the gold standard. In conclusion, to echo the ASMBS statement, we need more data to determine whether bariatric surgery should be considered as frontline therapy. Because adult data available shouldn't be translated to our adolescent population. There's insufficient short and long-term data in our adolescent population to make strong recommendations. Bariatric surgery can cause significant complications in adolescent patients, and bariatric surgery is not an equitable or universally available treatment option. So, in sum, we should not recommend bariatric surgery as the treatment of choice for NAFLD in adolescents with obesity and moderate fibrosis at this time. And here are my references. Thank you.
Another outstanding talk. Thank you. I really enjoyed these two talks. I've learned a lot actually from the presenters thus far about this adolescent group. So enjoying this very, very much. We're going to now turn to the rebuttals. So I'd like to ask Dr. Eric Debroux, who's from CHLA, who's going to rebut the Children's Hospital Colorado position. Eric?
Yes, hi. Thank you, everybody. Thank you very much for allowing me to talk. I'm happy to address any of the concerns that were brought up by our colleagues in Colorado. I think, importantly, I think the first comment is something that is important that all of us as pediatricians have dealt with, and that is that, they're just in terms, at least with our adult colleagues deal with, we're always faced with the limited data. And as such, as pediatricians, we're all forced to really rely upon what's in comparison, a much more limited amount of evidence in the pediatric population, and then use extrapolation of adult data to really come up with ways to approach our clinical considerations. I think it's important noting that the data that is available that my colleague has presented has shown that at least in adolescents, which again, this is absolutely correct that, pediatric population is not necessarily going to be the same as adults, but certainly in the older adolescents, at least physiologically, we're dealing with a population that probably does resemble more adult physiology, and certainly the data seems to show very similar outcomes, at least in terms of their both other complications as well as the weight loss that seems to be providing for them. I think complications is certainly something that we all must talk about for any intervention that we're proposing. and bariatric surgery, of course, being no exception to it. I think that, the long-term complications that were mentioned have since been evolving over time, especially with the development of new modern surgical techniques. For example, and I think they quoted some of the, like almost 20 to 25% of patients needing reoperative procedures following their bariatric surgery. I think there was a study in Sweden which had similar amounts of reoperation necessary, and what they really were focusing on, that most of these reoperation events were cholecystectomies, which were becoming less and less with routine use of ursodiol following bariatric surgery. And then also, of course, the risk of small bowel obstructions, which again, modern surgical techniques, including closure of mesenteric defects. And then I think also importantly, the switch to more and more of a sleeve gastrectomy, is going to really decrease the amount of long-term complications and need for repeat surgeries that was seen in these previous studies. Similarly, in terms of vitamin deficiencies, I think there's been a greater awareness of them. I think the previous studies were very smart in picking adolescents who have finished most of their growth. And then I think there's just greater awareness of the need to follow these vitamin deficiencies closely. And then again, the move towards a sleeve gastrectomy, we should, in theory, be seeing less and less of these vitamin deficiencies develop post-surgery. And, I think we also, as pediatricians, especially those of us who also do hepatology and liver transplant, we're used to working in a very multidisciplinary way in specialized centers. And I think this is something that I don't disagree with our colleagues, but this probably is something that might be similar in terms of developing a program for bariatric surgery in these patients, because they probably will require a more comprehensive multidisciplinary team than our current a general approach in a GI clinic. And so I think to end there, I think we're really looking at the data that we have presented and I think really stressing the lack of alternatives, because I'll say what data is also available is the fact that the current cornerstone of NAFL treatment in the pediatric population, which is diet and exercise, really doesn't work. And so what we're trying to deal with now is a population of patients where we really have nothing to offer them. And so I think in this, if a carefully selection of a patient population selection, in this case, we're talking about adolescents with moderate fibrosis, I think that the bariatric surgery should be entertained, as it has been shown to be effective and safe, and really given the lack of alternatives, as well as the need to reduce the risk of NAFL progression, that we really should consider this to be a treatment of choice in this population. And I'll stop right there.
Great, thank you so much. That was terrific enjoying this. Okay, so now we're gonna ask Dr. Priya Rolfs from the Children's Hospital in Colorado to now rebuke the CHLA position. Priya?
Great. Thank you so much. And thank you to our CHLA colleagues who've presented a lot of data in favor of bariatric surgery as treatment for NAFLD in adolescents. But there are a few points that I'd argue prohibit this invasive and high-risk intervention from becoming the treatment of choice for pediatric NAFLD population, specifically with moderate fibrosis, which is the question at hand. The CHLA team presented a lot of data demonstrating the benefits of bariatric surgery in adults, but I'd like to revisit the point that adolescents are not the same as adults. And in pediatrics, we often say that kids are not just little adults, and that really holds true when we look at the pathophysiology of NASH. We have evidence to support that the pathophysiology is different in adults versus the pediatric population. In 2005, Schwimmer and his colleagues demonstrated that children exhibit differences from adults in key histologic features, such as frequent portal inflammation and fibrosis, but less frequent hepatocellular ballooning injury, lobular inflammation, and perisinusoidal fibrosis. This was further supported in the TONIC trial in pediatrics and the PIVENS trial in adults, both of which studied the histologic effects of vitamin E treatment in these populations. And in the pediatric population, there was no significant comparative improvement in lobular inflammation or steatosis found with vitamin E treatment as there was in the adult PIVENS trial. Secondly, while the CHLA team showed us some adolescent data to support bariatric surgery, we have more data to support that lifestyle modifications do indeed work, which I know you said don't, but we do have evidence to suggest that they do. And they certainly are a safer option for our population in question. We have studies that show intensive weight management programs demonstrate success in improving NAFLD in adolescents. Nobility in 2008 published a study demonstrating that lifestyle intervention with diet and increased physical activity over 1 year was associated with significant improvement in liver histology and laboratory abnormalities in pediatric NAFLD patients. And then just in 2021, Moran Lev et al. Had an RCT that demonstrated conservative management works as well. So low carbohydrate, low glycemic load, and isocaloric diets resulted in decreased fibrosis shown by elastography after only 3 months of intervention. And then even Dr. Coley from the CHLA team in 2013 published a study that demonstrated success in improving NAFLD with a clinically feasible intervention where patients were followed up in a multidisciplinary clinic every 3 months, which of note is the same intensity of follow-up as bariatric surgery patients. And after a year of follow-up, mean BMI was stabilized with significantly improved aminotransferase levels. And from a safety perspective, I just want to point out that adolescent studies that our opponents cited, I think it was the INJ 2018 study, they actually do have significant safety concerns, and that is a more recent study. So 13% of patients required repeat abdominal surgery due to complications, as Dr. Goldberg mentioned earlier, my colleague, and they also demonstrated significant micronutrient deficiencies. So while vitamin supplementation is possible, we know that, we also know that consistent compliance in the adolescent population is particularly challenging, and they did see that in that study. It's also important to remember that there might be implications in this population that are unique for bone health, for example, and these patients are continuing to grow. And then we also can think about the serious implications of folate deficiency in a population that's of childbearing age. And so as a result, we really need further studies to address these concerns. So, while we know that micronutrient deficiencies are present, we need studies to show that what the long-term outcomes are before we can recommend this as the treatment of choice for this population. So just to summarize, while bariatric surgery could be considered as a therapeutic tool, we need more RCTs specifically in the adolescent population, and it's premature to consider it as a frontline therapy for NAFLD with patients with fibrosis with the data that we currently have. We have plenty of evidence to support the efficacy of conservative lifestyle management, and we should be asking ourselves how we can innovate to increase compliance with these lifestyle changes rather than subjecting our adolescents to high-risk, life-altering, and invasive surgery with unknown long-term outcomes. And finally, I would just like to add that the market for NAFLD drugs is estimated in the $35 billion range. Millions of dollars are being poured into research and development for NASH. And it's only a matter of time before we have safer, more cost-effective, and more universally accessible interventions that in conjunction with lifestyle changes will become the treatment of choice and allow us to make a dent in those rising rates of NAFLD in the adolescent population that the CHLA team presented initially. Thank you.
Excellent. So thank you all. Those are terrific presentations and rebuttals. So now we're going to move on to the question and answer portion of this program. So I'm very much looking forward to hearing what our judges have to say. So if I could just ask all of our presenters to come back on camera so we can start to line you up for questions. And I'm going to start, this time I'm going to go reverse order. So I'll start with Dr. Ayu. If you want to lead off the questions for our pediatric teams.
Sure. That was a quite educational for me, being an adult hepatologist. So thank you for, it's a great presentation and information. I learned a lot. So my question for the Los Angeles team. So after listening to the Colorado team, would you change your position toward selecting certain group of adolescents for bariatric surgery, or is it one rule for all?
Yeah, so thank you. I mean, I think that the body of evidence that we presented is really in the adolescent population. And certainly, and again, because some of these complications, especially vitamin deficiency, probably does matter more in the child who's going through their physiological growth spurt, excuse me. In addition, some of the studies, including the one that they quoted from Dr. Coley and Dr. Schrimmer, are really looking at pre-adolescent children. And so really, again, that's probably actually a much more different population than the adolescent, who I would favor would be closer to kind of, at least physiologically, what we're seeing in the adult population. And so probably, I think, again, restricting them to the kind of the older adolescent range. And again, we're already focusing on adolescents who already have developed pretty severe fibrotic changes in their liver. And I think that was really the population that we need to intervene on, and we need to do it in a timely fashion. Because I think just waiting until they're of adult age before allowing them to get a bariatric surgery is probably not an appropriate thing to do at this point in time, unfortunately, just by the age at which we're seeing them present.
Can I add something?
Nisam, you're muted.
Okay, can you hear me? So
Yes.
yeah, I'm going to absolutely keep my position stance. And I think one thing to really keep in mind is what Eric said is the timely fashion of this bariatric surgery, because a lot of the, a lot of the reversible cardiometabolic changes that occur, you have to be mindful that that's actually more for adolescent time frame. It's less reversible when it comes to adult population. At least that's what we know from pediatric literature. And when you think about what our studies are suggesting, even in adolescent population, we're talking about remission of type 2 diabetes in 94% of the patients, remission of dyslipidemia, remission of prediabetes. So micronutrient deficiency is actually not that compelling of an argument when you think about that these are things that can easily be followed in an adolescent in a multidisciplinary setting. And it's not a good enough reason to avoid, all the benefits that bariatric surgery has to offer in this patient population that will progress to liver disease. Because what we know is that these patients, in terms of how obese they are, they're not going to do well in the long run with lifestyle interventions. That's what the studies show. So this has to be a treatment option, a treatment of choice.
Maybe I'll just give a second for the Colorado team to chime in.
Yeah, so thank you. So I guess my question would be, when we're talking here about patients with moderate fibrosis, and that is such a small percentage of the population. So if we are recommending this, are you planning on biopsying every single patient that comes to you before recommending bariatric surgery? Sort of how would you approach that?
I'm not sure. Is that allowed that they can ask questions? A new strategy in the debate.
Rhetorical.
A rhetorical question. Okay. All right. I love that. Okay. We're going to move on to Dr. Chung. Sorry, Waleed, did you have another question? I don't want to cut you off. Sorry.
Sorry, I just want to ask quickly as a Colorado team. They
Please.
mentioned the $35 billion market coming up for NASH drugs. But if you look at it, bariatric surgery is one time, and the patient don't need to take a lot of medicine afterward. While if you go the medicine route, now we don't know how long the patient needs to stay on these medicine so far. So one argument is do the surgery. It's much easier and better compliance afterward than going on the medicine for life. What would you say?
Yeah, I think that the important part of that is that the cost of a drug coming out, we don't know yet, versus we know that there's a significant cost of bariatric surgery in addition to the need for frequent follow-up with a lot of supplements and medications in the long run. And for individuals and families, that some of the post-bariatric medications include vitamins and supplements that aren't covered by insurance. So from a patient inequity standpoint, that medications covered by insurance might be a better and more equitable choice anyway.
Very good. Thank you.
Great. Okay. Dr. Chung.
I want to chime in and also congratulate both teams for really just educating all of us on again, a super important topic. You both made crisp and eloquent arguments on both sides, and again, fantastic work. So there are no losers in this. You are all winners. With that, I would just ask, perhaps I'll ask the Children's Hospital of LA group what they think about the notion of the merits of waiting for approvable therapies for either NASH itself or for weight loss. We are certainly hearing much more about agents in both of those arenas, given the moderate fibrosis that these adolescent children have. Can we justify a waiting approach? I'd love to hear your thoughts on
that. Thank you. I mean, I think that we are also eagerly awaiting kind of the new therapeutics coming down the line. Of course, you know, I think we're going to be facing the same problem that Colorado was objecting to, and that data is probably going to be based on very limited pediatric studies with extrapolation of adult studies of these medications. And so again, you know, how long do we wait? And is that going to require another 5-10 years of evidence on top of what's already been accumulated? I don't know. The fact of the matter is, you know, we continue to see adolescents presenting again with pretty extensive fibrosis, and to just say, let's just wait and see what happens 5 years from now is becoming, unfortunately, less and less of an option. And so, and again, and I think that kind of echoes a little bit of kind of what they've seen in terms of the few RCTs they've done where they've randomized to either bariatric surgery or conventional therapies. And again, the conventional therapy group in adolescents tended to gain weight. And then once they became adults, they got the bariatric surgery anyways. And they just had worse off liver fibrotic changes then. And so the question not so much is like waiting for better option. It's just like, well, how long do you let these changes and potentially damage accumulate over time? And is that really fair?
Sure, and to that point, children who like develop fibrosis, these very severe phenotypes, are probably like the most affected individuals. And one thing that the New England Journal of Medicine article really mentions, that it really states that the changes that we see in adolescence, the weight, the glycemic control, blood pressure, as a result of bariatric surgery, these changes might actually be less reversible as time progresses, and what they call more like pound years will accumulate. So in this situation, I wouldn't advocate for waiting when you have a patient who will very quickly progress to end-stage liver disease.
Ray, I'd like to give the Colorado, Children's Colorado, an opportunity to respond to that question also.
Yeah, I think we're not debating the efficacy of bariatric surgery for obesity. I think the topic at hand is should this be treatment for patients with NAFLD with moderate fibrosis? And again, it's such a small percentage of our population based on data that I presented. It's only 3 to 4% of our population. And in terms of waiting, I think our job as physicians is to first do no harm. And this is such a slowly progressive disease that it's better to have the evidence and know what we're going into and not jump to making recommendations that we don't have evidence for our patients.
Dr. Chung, do you have any follow-up questions?
No, thank you very much. I would just ask perhaps the Colorado team if they are, how they would manage that moderate fibrosis patient if not bariatric surgery. What would their approach to that patient be to manage that NAFLD with moderate fibrosis?
Yeah, thanks for the question. So I think at this point, we would favor a more conservative but very intensive lifestyle change approach. And so following some of the studies that we talked about, that I talked about in my rebuttal, following the patient every 3 months in a multidisciplinary clinic that has a registered dietitian and has, the hepatologist, or even monthly, following them monthly would be our choice at this point.
All right, and finally, Dr. Chernoff, please, questions for our debaters.
I have a question for the Los Angeles group. I would be very interested in knowing what the longest quality of life and data follow-up on the post-op population is that you folks came across?
So certainly the randomized control trial in the Sweden group did up to 5 years. And it's probably one of the longer ones. A lot of them, especially the ones focusing on surgical complications, especially immediate, as well as kind of NASH resolution, because that time point comes earlier. A lot of them did stop sooner than that, but certainly, there's been increasing attention to the need to really providing a more longer term follow-up. But certainly up to 5 years has been described, and that I think was following about almost 90 adolescents.
That's actually much longer than I was expecting. Again, I salute all of our competitors tonight, and 2 really stimulating topics. So thank you all again.
Great. Well, I would echo that. Amazing presentations this evening, and I've really, really enjoyed. I learned a lot from both of the sessions this evening, which is always the purpose here, as we come away a little bit more informed by the presentation of the 2 sides. So we're going to, while the judges are deliberating, and before we conclude our debate tonight, I just want to make sure that I, again, express my gratitude and gratitude on the part of ALF for the generous sponsors for debates this evening. I really want to just say this is such a great activity. And of course, we recognize that sponsors are very important for this. So again, thanks to both AbbVie and Eisai for their sponsorship of the academic debates. We're very, very grateful. We also want to just thank all of you for your time that you've spent today. And just before we leave and before we learn about the winners, I just want to encourage you that this is the time to make a donation to the American Liver Foundation. I reviewed with you the very important work that they're doing. I checked out the link. It's actually really easy and fast to do. So really take advantage of this time to make a donation and support the work, support what this foundation can do for our patients, caregivers, and for our colleagues. And while you're making a donation, we're going to begin our closing remarks. And again, I just want to congratulate the teams this evening. Really an outstanding job. It was really really spectacular. So congratulations also to the mentors for providing their expert guidance here. And I want to, of course, thank our 3 judges for providing, I think, thoughtful questions to gain more insights yet into the sides of the argument. And then finally, the ALF tech team and all of you for joining. Just as a way of reminder, the debate madness is going to continue. This is just the first night. So please register for the important virtual programs and promote them within the communities where they are going to be occurring. And then again, also to remember to visit the ALF website, recommend it to your friends, family, colleagues, patients. Again, many resources available to patients and their caregivers. And you can see them here on this slide. It's really an amazing resource. And then, of course, use social media to really support the broader vision. As a hepatologist, I think we can't possibly go far enough to get the word out about the importance of liver disease. And really, this is both, for our patients and their families. And again, the great work that ALF does in this regard is really helpful in raising awareness. What you see on this slide here is the Liver Life Walk, which is a signature event that the ALF hosts. It allows people affected by liver disease to come together to raise awareness and funds. It also gives them the opportunity to support each other in a festive and kind of fun environment, and everybody feeling very inspired in doing so. And we're happy to announce that in 2022 that we are planning to host 13. We're finally back to doing in-person walks across the country. There'll also still be virtual walks, but really visit the liverlifewalk.org for more information about this. It's exciting to see it back. And then there's also the Liver Life Challenge, which is the American Liver Foundation's official endurance program, where dedicated athletes across the country use their passion and commitment to come to go the extra mile for the liver community. So really need you to be aware of this. This is run or ride with the ALF and their athletic partners in 2022. So you can visit the liverlifechallenge.org to take part in that challenge. And then finally, the legacy galas recognize individuals who make outstanding contributions to the liver community. This has always been really one of the favorite things for me to look forward to in the year, where we sort of recognize the amazing work that's done in the fields of biotechnology, medical innovation, philanthropy, and broader areas related to liver disease. Both galas will host patient families, medical professionals, organizational partners, and business visionaries in the realm of healthcare, pharmaceutical, and biotech industries. So to learn more about the upcoming galas in May and October, please visit the allfgala.org. The judges are working away, so I'm just giving you some sort of good information here while we wait for their final decision. So I also want to speak about the ALF's advocacy, really a very, very critical and important role. They represent more than 100 million Americans affected by liver disease. Together with volunteers and coalition partners, the ALF advocates on behalf of their liver patients, their caregivers, and all those impacted by liver disease for increased federal research funding, public health education, and improved patient treatments and coverage. So here you'll see the ALF advocates. To become an ALF advocate, you can learn more at the liverfoundation.org/advocacy. A few other sort of important areas that the ALF is focused on. One is biliary atresia, and I think this is very appropriate given our pediatric emphasis this evening, where we learned about the very important aspects that, you know, there are unique diseases in pediatrics, and really there are diseases we share in common between adults and adolescents, as we learned tonight. But the American Liver Foundation has built a private Facebook support group community of biliary atresia family members and patients. It's moderated by an ALF staff member and a biliary atresia patient and parent. And it's going to launch in April, on April 6th of this year. So this is a very unique community. It's there to provide a peer network, reliable information on biliary atresia for families and those that have questions, and will have exclusive monthly educational programs from pediatric liver disease experts on different topics related to biliary atresia and that whole journey for those patients and their families. So this is a very unique and important new initiative. So you'll see that there is a share with your patient, an opportunity to share with your patients that may be interested in this in the Liver with Biliary Atresia Facebook support group. And then one more, that the ALF is there to bring together those of us interested in liver disease, including those that are rare diseases. There are up to 50 rare liver diseases, and there's an interest in bringing together patients, caregivers, hepatologists, primary care physicians, patient advocacy organizations, and industry representatives into a stakeholders roundtable. It's a 4-hour virtual roundtable that's seeking to identify solutions for improving the outcomes of individuals who have these rare liver diseases. And the meeting that you'll see here, you'll see the invitation is at the bottom there, is focused on answering the key questions. How do patients avoid misdiagnosis and achieve earlier diagnosis and earlier connection to care? How do we educate more patients and more people about genetic testing and to best address concerns around stigmatization? And finally, how do we reduce the patient burden and overall improve the patient experience. So please find out more in terms of this first ever Rare Disease Summit. Okay, so I do think that I now have allowed the teams to, the judges to have made their selection. So I'm going to have all the teams join me. And I just, again, want to just say what an exceptional evening this has been and how much I've enjoyed moderating. So I want to thank the ALF for this opportunity, but again, to congratulate all of those that participated this evening for an outstanding evening. So to the debaters, thank you for educating us. I think we all learned a little bit this evening. There's never a right answer, but you helped us kind of understand the different sides of that question. There were really important things that we learned through this. So we want to thank you, did an outstanding job. And I think we all came away a little bit smarter. So I think Ray said it, and so did several of the other judges. There's, you know, you're all winners. It's true. It's absolutely true. And I think you're winners because you were, you know, willing to do this. It's always a great, fun for all of us, but a lot of work on the part of the teams that actually had to present and their mentors. So we want to just thank you for doing that. But there are winners. There is a winner. And so I'm going to announce the winners. Okay, it came to me on my phone. So the winner of the first debate is the University of Southern California. We'll set, prizes are in the mail. Okay. And the winner of the debate number 2, our pediatric colleagues, is Children's Hospital of Colorado. Fantastic. But truly, you all are winners. I really do mean that. It was fantastic. Okay, great. Well, again, I'm going to thank you for joining us this evening. And this is the end of our first Academic Debate Madness week. I really hope you've enjoyed yourself. I've definitely had a good time. I'm going to just know that tomorrow both participants and attendees are going to be receiving an email from us asking you a little survey about how tonight went and asking you for input. We always appreciate your feedback. And really, I hope you'll continue to join us through the week for the rest of the Academic Debate Madness. With that, I want to say thank you. It's been a great pleasure.